Personality disorders, the maladaptive architecture of the self. Personality disorders, PDs, represent a third, fundamentally different organization of psychological distress. Unlike neurosis, where the problem is a symptom that intrudes on the self, and psychosis, where the problem is a break from reality. A personality disorder is the problem. It is an enduring, rigid, and deeply ingrained pattern of inner experience and behavior that deviates markedly from the expectations of the individual's culture, is pervasive across many areas of life, is stable over time, and leads to significant distress or impairment. These patterns are typically rooted in deep-seated issues of identity, interpersonal functioning, and emotional regulation. PDs are defined by their pervasiveness and ego-centricity. The client does not see their behavior as a problem. They see the world and other people as the problem. The symptoms are integrated into their very sense of self. The impairment lies primarily in their interpersonal relationships and their inability to adapt their behaviors to differing social and emotional demands, creating a pattern of repeated relationship crises and self-sabotage that is deeply painful, even if the client denies responsibility. The symptom patterns within the most commonly encountered PDs, those in cluster B, illustrate a vast difference between ego-dystonic and ego-syntonic suffering. For a client with borderline personality disorder, BPD, the symptom pattern includes frantic efforts to avoid abandonment, unstable self-image, intense mood swings, and chronic feelings of emptiness. The emotional reality is one of relational chaos and internal instability. Their symptoms are ego-syntonic in the moment, as they genuinely believe they are being abandoned or betrayed by the people they love, and their emotional reactions are immediate and overwhelming. They cause immense distress in others, and their own pain is channeled into a persistent state of crisis, often involving self-harm or suicidal gestures as a means of regulating intolerable emotion. Contrast this with narcissistic personality disorder, NPD, where the emotional tone is one of entitlement and fragile grandiosity. These clients are ego-syntonic in their belief that they are superior, special, and deserving of admiration. Their abnormal behavior, exploitation, lack of empathy, arrogance, is seen by them as a necessary tool for maintaining their status, and their distress only emerges when their grandiosity is challenged, triggering a painful narcissistic injury that they project outward as rage. Finally, antisocial personality disorder, ASPD, is the most ego-syntonic of all. The pattern is characterized by deceit, manipulation, and a profound lack of remorse or empathy. The individual often feels no personal distress. Their behavior is seen as functional and effective, demonstrating that the abnormality is not always defined by internal pain, but by the external, chronic danger and dysfunction they inflict on society. The etiology of personality disorders is a powerful intersection of nature and nurture, with a heavy focus on early life experiences that sculpt the developing self. Psychosocial, primary. The prevailing view is that PDs stem from severe, chronic disruption in early attachment and emotional development. A failure to develop a secure, coherent sense of self and others is paramount. Linehan's biosocial theory for BPD suggests a biological vulnerability, high emotional sensitivity/reactivity, interacting with an emotionally invalidating environment, where a child's feelings are consistently dismissed or punished. This results in a failure to develop effective emotional regulation skills and a persistent, overwhelming sense of inner instability. Maladaptive schemas, cognitive models, suggest PDs are rooted in deeply ingrained, rigid, and global beliefs, schemas about the self, others, and the world. E.g., I am defective, the world is dangerous, people will always abandon me. These schemas become self-fulfilling prophecies, driving the maladaptive interpersonal behaviors. Genetic. There are genetic vulnerabilities, particularly for cluster B disorders, e.g., impulsivity and affective instability, demonstrating that the PD is a complex, transactional outcome between an individual's innate temperament and their environmental conditioning. Treatment for personality disorders is the most challenging, requiring long-term, specialized, and highly structured therapy aimed at fundamental personality change, not just symptom relief. Specialized psychotherapy, first-line, The gold standard treatments are those that focus on emotional regulation and interpersonal skills: dialectical behavior therapy, DBT for BPD, schema therapy, and mentalization-based treatment, MBT. DBT, for example, is an intensive, skills-based program that teaches the client 4 core modules: mindfulness, to reduce emotional reactivity; distress tolerance, to survive crises without making things worse; emotion regulation, to understand and change emotional responses; and interpersonal effectiveness, to navigate relationships without chaos. This structural change takes years. Pharmacotherapy adjunct. Medication is rarely curative but can manage certain symptoms, e.g., mood stabilizers for affective instability, SSRIs for chronic depression, anxiety comorbidity. The counseling approach. The counselor must act as a highly structured, consistent, and boundaried coach. The ethical challenge lies in managing countertransference, the counselor's emotional reaction to the client's intense, often manipulative or hostile behaviors, and maintaining therapeutic boundaries while fostering genuine attachment. The work involves validating the client's intense emotions while simultaneously teaching them new, effective ways to regulate those emotions and interact with the world. Ethical and cultural sensitivity across the psychopathology spectrum. For the ethical and effective counselor, the knowledge of these 3 distinct organizations of distress must be applied through a lens of cultural humility. A disorder is not just a list of symptoms. It is a human experience shaped by the client's unique cultural, social, and spiritual worldview. Applying clinical labels without sensitivity can lead to profound therapeutic failure or, worse, cultural trauma. The ethical mandate for working across this spectrum is rooted in 2 principles: competence, knowing the difference between neurosis, psychosis, and PDs to select the correct intervention, and non-maleficence, doing no harm. Cultural sensitivity for neurotic disorders centers on acknowledging the expression of distress and the role of the individual. In many non-Western, high-context cultures, e.g., parts of East Asia, Latin America, it is culturally inappropriate or weak to speak openly about sadness or anxiety. Distress is often channeled into somatic symptoms: headaches, stomach pain, chronic fatigue. A counselor must be trained to recognize that a client complaining only of physical pain may in fact be suffering from MDD or GAD, and the appropriate clinical questioning must respect this cultural norm, understanding that the client's primary emotional defense is to medicalize the psychological. Furthermore, Western CBT, with its focus on individual autonomy and self-mastery, may clash with collectivist cultural norms where self-worth is derived from the group, family, community. For a client from a highly collectivist background, the goal of setting boundaries or prioritizing personal needs may feel like a deep violation of their identity, exacerbating their guilt and anxiety. The counselor must redefine function to mean effective participation within the client's familial and cultural system, rather than demanding a Western individualistic outcome, lest they accidentally pathologize the client's heritage. The cultural challenge in working with psychosis is centered on the interpretation of reality and sensory experience, spiritual ancestral communication. In many indigenous, traditional, or religious communities, the experience of hearing voices or receiving messages is not a sign of deviance, abnormality, but a sign of spiritual connection, a gift. A client from these backgrounds reporting auditory hallucinations may believe they are communicating with ancestors or a deity. The counselor should never validate the delusion, which would be unethical for psychosis, but must validate the client's spiritual framework. The ethical approach is to use the symptom-function split. I respect your belief that this is your ancestor speaking to you, and I can see that when the voice commands you to stop eating, it causes you physical distress and makes it hard to live your life. Can we agree to work on ways to keep the spiritual connection while minimizing the physical harm it is causing? This approach respects the client's cultural truth while intervening on the dysfunction and danger. Crucially, in many cultures, the entire family system is involved in the care of the person experiencing psychosis. A culturally sensitive counselor understands that isolating the client for individual therapy can violate deep-seated norms of family responsibility, and must therefore work with the family unit for education and support. Finally, working with personality disorders demands sensitivity to how shame, hierarchy, and relationship norms are managed culturally. Relational shame. In cultures where saving face is paramount, the core shame of a PD, example, the fear of being defective in BPD, or the fear of being seen as weak in NPD, is intensely amplified, making the direct confrontation required by specialized therapies incredibly threatening. Treatment must navigate the deep fear of public humiliation, perhaps by emphasizing behavioral change first before tackling core identity issues. Norms of deference and dependence. A client presenting with symptoms of dependent personality disorder, pervasive need to be cared for, submissive behavior, may be fully functional and normal within a strict, hierarchical patriarchal culture where deference and dependence are the expected and rewarded female roles. The counselor must assess the distress the behavior causes the client and the impairment it causes them when they are outside that specific system, rather than diagnosing them simply for adhering to a dominant cultural script. Conversely, a client with NPD from a culture that rewards ruthless corporate ambition might be highly functional until their arrogance causes a devastating public-facing failure. The cultural norm temporarily enables the disorder until the point of inevitable social collapse. The ethical counselor's role is to use cultural knowledge to predict where the client's rigid personality structure will inevitably conflict with their environment, be it social, familial, or professional, and help them build skills for flexibility. In the final analysis, the differentiation between neurosis, psychosis, and personality disorders is the fundamental classification tool for a mental health professional. Neurosis represents ego-dystonic suffering over a functional reality. Psychosis represents a rupture of reality testing, and personality disorders represent an ego-syntonic, pervasive maladaptive structure of the self. The ethical counselor utilizes this knowledge not as a fixed set of rules, but as a dynamic framework, constantly adjusting the definition of abnormal to acknowledge that the client's profound emotional reality is always and profoundly mediated by the unwritten laws of their culture. This complex, nuanced understanding is what separates a technician of the DSM from a compassionate, effective healer.